Recording, and you can start your presentation.
Respected Chairperson, my seniors and juniors, very good afternoon to all of you. At the outset, I would like to thank Dr. Alpesh Gandhi, President FOXY, Dr. Jaideep Tang, Secretary General FOXY, Dr. Radha T, Organizing Chairperson of this event, and entire organizing committee for giving me this opportunity. India is one of the most populous countries in the world. Adolescents constitute about 1/5 of India's population. Furthermore, the young people constitute about 1/3 of the total population. In absolute number, as per 2011 census, there are 253 million adolescents in India, which is more than 20% of the world population. According to Oxford Dictionary, adolescent is a transition period from childhood to adulthood. Hollinshead has said, adolescence is that period of life of an individual when society no longer views her or him as a child, but does not yet concede her or him either the roles or function inherent in the status of the adult. Adolescents are full of energy, have significant drive and new ideas. The relatively lower death rate and relatively good health status of the adolescent has always been a misleading measure to adolescent health and thus giving lesser priorities. Many serious diseases in adulthood have their roots in adolescence. The main health issues faced by adolescents are mental health problems, abnormal uterine bleeding, early pregnancy and childbirth, HIV, sexually transmitted infection, violence, unintentional injuries, malnutrition, and substance abuse. Today, my talk is abnormal uterine bleeding in adolescents. It is defined as bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and or regularity. AUB accounts for half of the gynecological problems among adolescents. An Australian cross-section study showed that approximately 25% of the girls had significant AUB affecting life activities and resulting absence from the school. Some adolescents consider this abnormal bleeding as a normal. The underlying factors that cause this AUB itself may have potential for long-term health consequences and decrease in life quality. Adolescents with AUB can have a concomitant bleeding disorders. Approximately 1/4 of the adolescents who require hospitalization or blood transfusion may have coagulopathies. This is a normal menstrual cycle. We all are aware, so I'm not going into detail. Menarche usually occurs between the age of 22 to 23 years. The normal cycle of an adolescent female occurs every 24 to 31 days with bleeding lasting between 2 and 7 days. The frequency of cycle decreases if the age of menarche is high. Usually, menstrual cycles are established of 21-34 days, similar to adult in 60 to 80% of the adolescent by third year after menarche. It has been reported the chronic loss of more than 80 ml blood is associated with anemia. The International Federation of Gynecology and Obstetrics recommends the use of the term AUB to describe any aberration of menstrual volume, regulation, duration, and frequency in women who are not pregnant. FIGO also proposed the discard some definition from accepted terminology such as menorrhagia, metrorrhagia, hyperhypomenorrhea, polymenorrhea, BUB as they are controversial, confusing, and poorly defined. So these are the FIGO recommendation for AUB are disorders in regularity, disorders in frequency, disorder in amount of flow, and disorders of duration of flow. Acute AUB is an episode of bleeding in a woman of reproductive age who is not pregnant and of sufficient quantity to require immediate intervention to prevent further blood loss. Chronic AUB is defined as bleeding from the uterine corpus that is abnormal in duration, volume, and or frequency and has been present for the majority of the last 6 months. The FIGO's classification is PALM-COIN classification. PALM stands for the structure, the problem, and COIN stands for the non-structural anomalies, and N stands for entities not yet classified. So you can see the picture. P is polyp, A adenomyosis, L leiomyoma, and malignancy. These are the structural causes, and the non-structural are coagulopathy, ovulatory, endometrial, iatrogenic, and N is not otherwise classified. Structural problems are rare in adolescents, that is reported as 1.3 to 1.7%. Anovulatory cycle, which may manifest as amenorrhea, oligomenorrhea, or heavy menstrual bleeding with or without dysmenorrhea, owing to immature hypothalamic pituitary axis, and are most common AUBs in adolescents. Coagulopathy prevalence is reported to vary between 5 to 28% among hospitalized adolescents with heavy menstrual bleeding in different studies. So these are the most common causes of AUB in adolescents are ovulatory dysfunction, that is anovulatory, polycystic ovarian syndrome, thyroid disease. Coagulopathy is most common are platelet function disorders. In endometrium, in India, we have to think about genital tuberculosis. Then iatrogenic because of a breakthrough bleeding, and pregnancy, it can be intrauterine, ectopic, or gestation trophoblastic tumor. Heavy menstrual bleeding is the most common clinical presentation of AUB. Formerly, it was called as DUB, now refers to AUB, which is not caused by structural regions of the uterus. Delayed or absent ovulation can in anovulation and polycystic ovaries can result in lack of progesterone, and there is excessive estrogen. This causes excessive proliferation of the endometrium. So when the withdrawal bleeding occurs, it is heavy bleeding. For these reasons, anovulatory cycles are the leading cause of heavy bleeding, menstrual bleeding during adolescence. So I would like to evaluate a case of puberty menorrhagia. She's a 13-year-old girl, complains of continuous, moderate, painless bleeding for last 24 days. Age of menarche 24 days back. There is no history of easy bruisability, epistaxis, or gum bleeding. No significant personal and family history or any drug intake. Not sexually active. On examination, vitals are stable. Weight 50 kg, mild peril, no petechial hemorrhage, per abdomen soft, no organomegaly, PSPV, not done. So these are the investigation I will suggest. And remember one thing, investigation should be done before you start the treatment. Now there is a role of pelvic ultrasonography and adolescent because it is non-invasive and majority of them in AUB, it is a normal finding with additional information about endometrial thickness and PCOS picture. Remember one thing, the endometrial biopsy is not required for these young girls who has thickened endometrium. Congenital uterine AV malformation are very rare cause of menorrhagia in adolescents. However, it can be diagnosed on Doppler ultrasonography or on MRI. Patel et al. In the retrospective study of 230 adolescent girls with AUB 156 underwent pelvic sonography and they found 72.4% had a normal finding, 6.4% had PCOS morphology, and 1.3% had structural anomalies. Hence, they concluded the most common diagnosis for their AUD was an immature hypothalamo-pituitary ovarian axis. So our patient with puberty menorrhagia, her hemoglobin was 10.5 grams per cell. ESR, thyroid function, coagulation profile, ultrasonography, X-ray tests were normal. So she was labeled as diagnosis and ovulation. Now there are studies, it reports, if a girl attained the menarche before the age of 12 years, then it takes 1 year to establish the ovulatory cycle. If it is 12 to 13 years, then it takes 3 years to establish the ovulatory cycle. And if it is more than 13 years, it takes almost 4.5 years to establish regular ovulatory cycles. So the treatment is initial management of AUB adolescent is based on whether the AUB is acute or chronic. In cases of acute AUB, maintaining the patient's hemodynamic stability is very, very important. And remember, surgical invention are rare in adolescents, as most of these girls or patients, they improve with the medical line of treatment. So our goal of therapy is to decrease excessive bleeding, to provide hemodynamic stability, to correct anemia, to prevent recurrence, and to improve quality of life. So there are many pharmacological drugs used for the AUB, especially with the anovulatory abnormal uterine bleeding. They are NSAIDs, antifibrinolytic agent, ETHAMSYLATE, combination of estrogen progesterone and only pills, and iron and vitamins. TRANEXAMIC acid produces antifibrinolytic effect on competitively inhibiting the activation of plasminogen to plasmin. It prevents the untimely dissolution of hemostatic fibrin, which stabilize the fibrolytic activities, which stabilize the fibrin structures. It increases collagen synthesis and tensile strain with granulation tissue. Hence, it reduces both plasminogen activator and plasmin in menstrual blood of patients with menorrhagia. And therefore, there is significant reduction in blood loss in primary heavy menstrual bleeding as well as IUD-induced menorrhagia, and it is dose-dependent. There are clinical efficacy. It has been reported that tranexamic acid reduced mean menstrual blood loss in menorrhagia by 54% as compared to mefenamic acid, which is 20%. And there was no reduction seen in ethamsylate group during 3 pre-treatment cycle and 3 post-treatment cycles. Srivas et al. Conducted a small pilot study comparing oral tranexamic acid to combination of oral estrogen therapy pills for adolescents with heavy menstrual bleeding. The result demonstrated tranexamic acid appeared to be effective in management of adolescent heavy menstrual bleeding, in reducing the menstrual blood loss and improving their quality of life. Dose recommended is 0.5 to 6 gram per day in divided doses, and it can be taken orally about 1 to 1.5 grams orally 3 to 4 times a day. You must remember it is contraindicated in severe renal insufficiency, hematuria, and even in the history of thromboembolic phenomena. There is theoretical risk of an increased thromboembolic tendency, but remember this is a theoretical risk. The most NSAIDs which we use are mefenamic acid. The mechanism of action of these NSAIDs are it inhibits prostaglandin synthesis by inhibiting the enzyme cyclooxygenase. In addition, mefenamic acid also inhibits the action of already formed prostaglandin by receptor binding, hence are considered most effective. So you normally see NSAID, which are mefenamic acid, are most commonly used in reducing the menstrual blood flow. Then mefenamic acids are involved in the process of myometrial contractions, endometrium shedding during menstruation. It significantly reduces endometrial and plasma prostaglandin levels. It also exerts antispasmodic, anti-inflammatory, analgesic, and antipyretic effects. Mefenamic acid given in patients with menorrhagia significantly reduces blood loss up to 40% and uterine contraction by 60%. The dosage of tranexamic acid, if we combine tranexamic acid and a mefenamic acid, they are the most effective in controlling the menstrual blood loss. So dose required is tranexamic acid 500 milligram plus mefenamic acid 500 milligram 3 times a day, which is sufficient to reduce blood loss of menorrhagia. There is another non-hormonal option that is ETHAMSYLATE. It is prostacyclin synthesis inhibitor, which prevents prostacyclin-induced vasodilatation and antiplatelet aggregation. It also believed to reduce capillary fragility. However, currently it is not recommended as it is not effective in the treatment of heavy menstrual bleeding as suggested by RCOG guidelines. So adverse reaction, as all of us are aware, like nausea, diarrhea, etc., which I'm not going to go in detail. So now we are with the conventional hormonal therapy in AUB. Estrogen alone, but it is rarely used. If you have to use, it can be used ethinyl estradiol or conjugated estrogen. Progesterone in adolescent, we prefer oral, but in some cases, intramuscular, intrauterine, subdermal implant can be also given. Combine estrogen and progesterone. Androgens are not favored because of their androgenic activities. In acute AUB, administration of exogenous estrogen causes endometrial proliferation, which hits the site of endometrium bleeding and provides hemostasis. And the administration of progesterone stabilizes the endometrial lining. So remember, when there is a heavy bleeding and you want to control it, so only progesterone may not act. So you may have to add estrogen, which will proliferate the endometrium, heal the site, and the hemostasis will be achieved. A trial of combined oral estrogen and progesterone pills can serve as a diagnostic and therapeutic approach to the workup of abnormal uterine bleeding in adolescents. It regulates menstrual flow, provides contraception, provides relief of associated dysmenorrhea, premenstrual syndrome, prevent menstrual migraine, and potentially reduce pelvic pain associated with endometriosis. Use of continuous contraception pill for 84 days are recommended, that is extended combined estrogen progesterone pill. It is really recommended in a patient who are anemic, so that every month menstrual blood loss is not there. In polycystic ovarian disease, due to chronic anovulation, can be infrequently associated with irregular heavy bleeding is reported in 30% of cases by Gozer et al. So this estrogen progesterone combination suppresses ovarian and adrenal androgen production and increase sex hormone binding globulin, resulting in improved symptoms of acne and hirsutism associated with PCOS, which is reported to reduce in 50 to 70% of women, and it also regulates the menstrual cycles. Progesterone only pills are indicated when the combined estrogen progesterones are contraindicated or they are not tolerated. The androgenic progesterone are given to arrest uterine hemorrhage. That is high doses of noritestosterone, 20 to 30 milligram per in a divided doses. And once the bleeding stops, you can taper it off and you can stop after 20 days or 21 days. Cyclic and non-testosterone acetate can also be given from 5th day to 25th day in dose of 5 to 10 milligram per day in a patient with cases of heavy menstrual bleeding. There are sustained release preparations are also available. So progesterone can be prescribed cyclically when the patient does not have heavy menstrual bleeding, but they have irregular delayed menses. So here we use medroxyprogesterone 10 milligram orally daily for 10 days, either monthly or every 3 monthly. The advantage of medroxyprogesterone is that it doesn't give rise to androgen effects on the patient. So patient, there is no heavy bleeding, they can be given medroxyprogesterone. The injectable can be used in certain cases. However, amenorrhea, irregular menstrual bleeding that many adolescents find bothersome and unacceptable. There is decrease in bone mineral density observed compared to the normal menstrual controls. But however, there are no high quality data is reported that the decrease in bone mineral density will affect eventual fracture risk in adolescents. It is a good option for some of the patients, but on a temporary basis. So management in mild cases of heavy bleeding where they are stable and hemoglobin is more than 12 grams per cent, but reassurance is the most important part. Menstrual calendar to be maintained. They can be given non-hormonal therapy with multivitamin and iron. One can re-evaluate the patient after 3 months, and if required, you can give the hormonal therapy. But patient with the moderate cases, when hemoglobin is 10 to 12 gram per cent and hemodynamically stable, you can give for the acute blood loss one pill 6 hourly for 24 to 48 hours or till the bleeding stops, and then taper it off till and stop after 20 days. One can give cyclical manner after that for 6 months along with iron supplementation and reevaluate after 1 to 3 months. In patients with severe menstrual blood flow, heavy menstrual blood flow, and if she's hemodynamically stable but cannot tolerate the hormonal therapy, she should be hospitalized till the bleeding stops. But when the bleeding is very heavy, it is life-threatening, hemodynamically unstable patient, and hemoglobin is less than 10 gram per cent, this patient requires hospitalization with IV fluid and, if necessary, blood transfusion. The high dose of the progesterone is given, high dose of estrogens are given, and one pill BID for up to 2 weeks. A high dose of estrogens are given, and if within 2 doses, if the bleeding does not reduce, then you may think of starting estrogen 25 milligram every 6 hours. But remember, it should not exceed more than 6 doses. Once patient bleeding stops, you switch over to the oral, and you should also supplement with progesterone, because if you give only estrogen, it will cause endometrial hyperplasia. So next withdrawal bleeding will be also very heavy. So it is recommended that you should supplement with the progesterone. So our concern are high dose estrogen therapy can cause nausea, which may result in decreased adherence. So consider anti-emetic. High doses of estrogen may cause premature closure of the growth plate, hence ultimately reducing the adult height. However, by the time of menarche, most female adolescents have already undergone their growth spurt and achieve approximately more than 95% of the adult height, so you need not worry. Then follow-up is very essential. We have to know whether patient is taking regularly the pill. She should maintain the menstrual calendar and she should report to the further therapy and subsequent episode of bleeding. The first follow-up usually after the next period. Thereafter 3 months, assess the response after 1 year to decide whether she should continue or she should not continue the treatment. Anovulation and AUB can be associated with increased body mass index. Exercise with associated weight loss may improve ovulatory function and therefore improves AUB. So diet and exercise education is an important adjunct to the medical management of these patients. Hypothyroidism can be associated with pubertal AUB. The reported incidence varies between 32 to 80% with heavy menstrual bleeding. The heavy menstrual bleeding associated with hypothyroidism respond promptly to the thyroid replacement therapy in the doses sufficient to correct the other manifestation of the condition. So this suggests that thyroxine does have a direct effect on a spiral arterioles and helps to reduce the menstrual flow. Heavy menstrual bleeding or irregular bleeding is observed in genital tuberculosis is probably due to ovarian involvement, pelvic congestion, or endometrial lesions. In 2050, Dutton and et reported in their series of 200 patients found that 2.5% had genital tuberculosis. So whenever the puberty menorrhagia patient comes, you must always, if they are not responding to your treatment, including hormonal line of treatment, one should rule out genital tuberculosis. 20 to 50% of adolescents with first heavy menarche bleeding are due to coagulopathy. The most common coagulation disorders are idiopathic thrombocytopenic purpura, von Willebrand disease, leukemia, and platelet dysfunction. So such patients should be treated with consultation with hematologists. The treatment remains the same. NSAIDs are contraindicated as they can alter platelet function and interact with drugs that might affect liver function and production of clotting factor. Intramuscular injection are to be avoided. If given, prolonged pressure should be applied at the injection site. So to conclude, most common of AUB in adolescent is caused by anovulation due to immaturity of hypothalamo-pituitary ovarian axis. Approximately 20% of adolescents have an underlying endocrine or a hematological disorder requiring targeted diagnostic testing. Individualizing every case, excluding pregnancy, timely hospitalization, a thorough history, physical examination, and baseline workup are crucial in management of every case. Reassurance, counsel of adolescent girls about the reproductive physiology, regular follow-up, balanced diet, exercises, and long-term iron therapy can go a long way in treatment of AUB in adolescents. I thank all of you for patient hearing. Mintu, my talk is over.
Okay, ma'am. Just give me a minute.
Mintu, can you, it is not now, recording is not done now? Recording has been stopped now? Mintu?
Yes, ma'am, it is stopped.
Okay. So how many minutes it was?